Can you do this in Canvas case? Can you do an H-step in front of that? We should all diagnose it. I want them to notice if you have ptosis in your eye.
Good morning.
Good morning, Sandy.
How are you?
I'm actually feeling better. I'm
Good.
not well enough that I'm feeling better, but I made the decision yesterday that I wasn't going to come in today,
Oh, okay.
even if I felt better. So it was just too great a risk. So
Well, I'm glad to hear you're feeling better.
for those of you who have desperately been trying to make appointments with me since Tuesday and you haven't been able to, it's because I've been sick. So it is not something that's contagious. My wife says I poisoned myself. I, I had I had an allergic reaction to something in a bottle of wine from Portugal.
Oh,
Probably either the pesticides on the grapes or the sulfites that they add as a clarifying agent for the wine. Uh, but
oh,
then,
wow.
but then I appear to have added some type of contact allergy also because the entire left-hand side of my face, it started just around my ear, but that swelling has gone down, but now the front right-hand side of my face is swollen. I
Okay.
have a fever on this side. I don't have a fever on this side.
Oh, wow.
Didn't know that was possible.
I didn't either. I am glad you're making your way toward good health now.
Yeah. So,
You were missed all week.
it's nice to be missed, but typically we don't recognize that we're missed until we come back. So,
All right, we're gonna start this.
Do you want me to start recording?
I guess we can start recording. And Dr. Warman, I guess we should start, and then I'll start.
Recording in progress.
Everybody can hear you. If you want to go ahead, you're on the big screen.
actually, there was one thing that I've discovered over the time frame from the last exam until now, going over the practical exams with a number of DO and MS students. The number of students that did not do well on visible body was somewhat surprising because you have access to visible body 24/7. Uh, what I came to realize was that although you have access to visible body 24/7, you're treating it the way you're treating plastination. And that is, you're waiting until the week or the several days before the exam and you're trying to memorize it. Visible body is not something that you can memorize because we can change the orientation of things. We can subtract things. But that also makes it easier for us to show you all of the information you need to know to be able to identify a structure. What I realized was we actually schedule 2 hours a week for every student to do visible body implastination. And I doubt that the majority of students are taking advantage of that 2 hours. I'm willing to bet that the vast majority of students are doing something else during that 2 hours. When you're not scheduled for dissection, what are you doing? I'm probably studying physiology or biochemistry or histology. No, you should be doing visible body and plastination. So, and that, if you do that, that will enhance the probability that you will do well on visible body and plastination on the next exam. How many people have already started looking at the heart on visible body? You know, you're not going to have a lab exam where you're going to be asked to identify pictures from visible body until the end of GI. So why should I bother looking at the heart now? I really wish that Mac wouldn't do this. So, and so you really need to take advantage of that 2 hours every week to do visible body and plastination. And if you're not, come the next practical exam, you shouldn't be surprised when you don't do as well as you thought you should on the questions on visible body. So, a lot of people thought we had class on Tuesday. That was a scheduled development of the respiratory system class. We moved it to the previous Friday so that it would be on the exam. So, so you got Tuesday off. I kind of doubt that's going to happen again. So, and I think that's all I have to say. Dr. Deruzo, I'll turn it over to you. They can ask questions, unless you
Oh,
have something to say.
so no, I just want to go over, we basically did the media signums. And we went over where they are, the location of where they are. So what we have to think of, just now, I'm gonna talk a little bit and ask questions, is we have to think of the lung cavity separate from the media sinus. So we want to think of the media sinus as dead center, going all the way from your trachea, going all the way down to your diaphragm. Your lungs are on the lateral aspect of that. We want to use our mid-clavicular line. We want to understand that for the mid-clavicular lateral, on the right-hand side is going to be the right lung, the left-hand side is going to be the left lung. Okay, so once you understand there are basically three compartments running like railroads, right, center, left, it's a little easier to get your orientation. Right. Now, next is we're going to look at anterior mediastinum, middle mediastinum, posterior mediastinum, just on locations. They're all under that sternum joint, that T4 vertebral level, the second rib. That makes sense. And you have to understand when we talk about levels, we talk about vertebral levels. But when we talk about landmarks, we may use the sternum joint, that second rib attachment. This good so far, thumbs up, thumbs down.
And although we say second rib, if you go to the vertebral column, you're looking at between T4 and T5, vertebral bodies.
Only level, the vertebral bodies and levels versus our landmarkers may be something else. It's on the anterior surface, we're all anchored in slightly different. Now, from there, when you look at your anterior mediastinum, most of us don't have one. Why? Because it was our thymus. So when we open up the rib cage, you just saw fat. Okay? And so what we have is fat there. And so it's like a pocket. And a pocket is a potential space, right? Only when you fill the pocket will it actually be filled with something. So the anterior mediastinum, when we watch x-rays, it will be air-filled shadow. There's nothing there except for fat. There's not much density there. So you want to know that it's got a little bit of fat because that's the retina of the thymus. It's essentially nothing's really there. It's a pocket. It's a potential space. Unlike the middle mediastinum and the posterior mediastinum, they're filled with objects. Okay, they're not potential spaces, they are spaces that are filled. And so your middle mediastinum, right, as your in your posterior mediastinum is everything that's behind that pericardial sac posterior. So you have your descending aorta. Everybody eat this morning? So you've got your esophagus. We have our vertebral bodies, so we know our sympathetic trunk runs down it. How about our azygous system? We would be considered that more posterior, right? Just now, lymphatics. So we want to make sure that we understand that that posterior mediastinum is behind the heart. Okay. So now that we have that in, we want to look at superior mediastinum. And so we use that T4 level, that sternum joint. There isn't an anterior superior mediastinum in a post, it's just superior mediastinum. That's the apex of us coming up. And so we want to think great best ascending aorta, arch the aorta, right? I like to use descending and thoracic aorta. Those are the way I was taught. Okay, but we want to make sure it's just the ascending aorta, the arch of the aorta, the proximal descending aorta, because that's the other side of the arch. Okay, and your great vessels. So we're going to have superior vena cava, right? The arch of the azygous wraps right into it. Okay, we're going to have brachiocephalic on the right, that brachiocephalic artery, brachial meaning it's going to the arm, cephalic meaning it's going into the carotid. On the left, we don't have that. We have our left common carotid, that makes the cephalic side, and we have the left subclavian. Right? So we want to make sure that you know one from the arch of the aorta, that you know from right to left, you're going to see three. On the one on the right, one. Left, you're going to see two arteries coming out that arch of the aorta. That's how you can size and face. How we doing? Just good? Just making sense? Okay. Now we have to understand thoracic outlet syndrome versus thoracic inlet. Okay. The thoracic inlet is your first vertebral body, thoracic, the first ribs, and your maneuver. It's that ring at the top. It does not involve your clavicles. Your clavicles are anterior to it. So that is your thoracic inlet going into the cavity. Thoracic outlet syndrome is when stuff is going out of the thoracic cavity, but it's been compressed, damaged, right? So you can have a tumor at the top compressing an artery, so not letting blood out to the arm. That's a thoracic outlet syndrome if something is in the thoracic inlet. One is an anatomical marker, and the other is conditions, medical conditions. So when we talk about thoracic inlet, we're talking about that T1 thoracic rib, T1 vertebral body, and the manubrium. How are we doing? Thumbs up, thumbs down. Is this helping? Is making good sense? Okay, so now parasympathetic versus sympathetic. Well, what is sympathetic? Dr. Mormon, we could show that he has got parasympathetic tone on his right side, but our left side, you see his eye drooping just a little bit? No, he doesn't have a Penco's tumor. Okay, he's got a swollen head. No, that's not ego. Okay, that is a reaction that he has. But what I'm showing is that you're sympathetic. You're getting ready to fight. So you're going to open up your eyelids so you can see the most amount. Your pupil is going to dilate. But your sympathetic chain is right on your vertebral body. So it's very easy to get compressed because it has a hard surface. There's no give in the vertebral bodies. So when you have a tumor at the apex, be ready for it to hit the sympathetic chain. One of the symptoms is, well, if we're cutting out sympathetic, what state are we going to go toward? So we want to think balance, right? One hand sympathetic, one hand parasympathetic. If we're cutting off sympathetic, we are now leaning toward parasympathetic. What do we do with parasympathetic? Rest, rest, right? Let's get sleepy. So sleepy. So your eyes will droop, your pupils will constrict. And so that's one of the hallmarks for a sympathetic chain disruption, right? Because the nerves that innervate our face from the sympathetic side, they have to go down your vertebral column and they innervate using the arteries. They wrap around the arteries and they go up to innervate our cranium and our face. Well, thumbs down. Is this making sense? This was a hard concept for me, so I didn't understand why. I thought the parasympathetic sympathetic go just right to the face. No, there's no way to get there because we're encased in bone. So they have to find another way. The sympathetics, they run up the carotid and then they go back. They have to come from the neck. That's why it goes down to go back up. Now to do our voice box, right? We have this recurrent thing. It's a recurrent laryngeal off the vagus. On the left side, it's around the arch of the aorta. Do we have a right aorta? No. We might have had one when we were younger, when we were little embryos, but we don't have them. So it's going to wrap right around that brachiocephalic artery slash subclavian branch right there. So you have to make sure that those can be compressed. And that's where we get hoarseness of voice. Because it innervates the current form to the larynx. So a zygous system is going to be on what? It is on the posterior, right by your vertebral bodies, right? So we notice the azygous system, I would consider not the intercostal vein because those wrap around, but the azygous, that confluence where they all come together. It's more of a posterior mediastinal, right? Because it's right on the vertebral bodies and it's behind the heart. The arch of the azygos, right? Did you notice in lab it came from posterior to the what? SVC. That's when it joins to the what? The kind of the great vessels. Right there. That's what the superior side when it comes off that high. No, arch. See, remember that's the arch of the azygos. That's when it reaches where we want to separate arch of the azygos from the azygos system. Right? And that makes it a little bit simpler because the azygous system is where we're getting all the blood from the rib cages and some accessory blood from the stomach. We have on the left side, we have our hemi, accessory, and superior. And on the right side, we just have our azygous system. They're going to all meet together, right? All that's going to drain when it branches over to the right to the azygous system. And then the arch of the azygos goes to the SVC. The SVC is where superior mediastinum. So everything below that T4 level, sternum joint, that's your posterior mediastinum. You have to understand the separation of what the height is, because that will tell you what mediastinum it's in. Superior, posterior, middle, or anterior. Anything you'd like to add, Dr. Mormon? Any questions?
Actually, I want to return to thoracic outlet syndrome for a minute, but it's not going to be obvious based on what I'm going to ask that I'm returning to thoracic outlet syndrome. When you go to the doctor, what side do they take the blood pressure on?
I know this one. Anybody? Give a guess. You got a 50% chance.
The left.
Left side.
Left side. Why? Because that's the side the machine's on?
You all know it. Don't think too deep.
The heart's on the left side, but that's the aorta, kind of comes out the middle and then turns to the right. And why take blood pressure on the left side? The left subclavian artery is a direct branch off the aorta. The right subclavian artery is a branch of the brachiocephalic trunk. That means that blood pressure is slightly higher on the left than it is on the right. Okay, what does this have to do with thoracic outlet syndrome? Thoracic outlet syndrome, most commonly, other than a tumor, is due to excessive coughing. You see thoracic outlet syndrome in mountaineers on Mount Everest. Because the air is so dry, they cough a lot. And I've been worried about thoracic outlet syndrome for the last 4 days. I have had thoracic outlet syndrome in the past. I had congestion in my right lung, and I knew that because of the slope of the right primary bronchus, I could turn my head and I could get a straight shot in from the trachea into that, from my mouth, trachea, and into that right primary bronchus, and I might be able to clear the congestion from my right lung easier. So I was doing that while I was running. But when you turn your head and look up to that side, you stretch the brachial plexus. And now you cough, and the apex of the lung punches the brachial plexus and the right subclavian artery. That causes swelling in the right subclavian artery, and it causes a compression injury in the brachial plexus. And so you get pain in the upper limb. And interestingly, because of the swelling, you get a decrease in blood pressure on that side. So if you think a patient has thoracic outlet syndrome, you should take the blood pressure on both sides. It's supposed to be higher on the left than it is on the right. And that difference is well documented, although they don't necessarily tell you what that difference is in courses like PD. If you have thoracic outlet syndrome on the right, that difference is going to be more dramatic. If you have thoracic outlet on the left, that difference is going to go away.
The normal difference is 5 to 10
The knowledge of anatomy helps you to understand a lot of what you see. Well, it helps you understand all of what you see clinically. And it helps anatomists to stop doing stupid things like turning their head and coughing.
No, you should have hung yourself upside down by your feet. I'm not hanging. Upside down by your feet, turn your head to the left, and slowly let all that congestion drain out of your mouth. That would increase your blood pressure to your head and give you a massive headache. So don't do that. All right, so we got thoracic outlet syndrome, right? We got a little bit of a tumor. Pancoast is a fast-growing tumor, so we know it's going to give you parasympathetic effects by cutting off that sympathetic chain. So we're doing good so far. Now, there is nerves that run right next to your pericardial sac. What nerves are those? Everybody take a breath and think about it. Which nerve is it? Phrenic, right? Because they run laterally to your pericardial sac. So a lot of the times, if you have inflammation of the pericardium, sometimes it's not that you won't be able to breathe, but you'll have some irritation. And irritation sometimes shows up as this. More hiccups. Right? So we just have to know that. Maybe if you had a tumor on your pericardial sac, right, or injury to your pericardial sac, what are we looking for? Look for heart damage, but also don't rule out phrenic nerve damage. You okay there? You doing good? All right. So now that we have that, I wanted to get to a little bit of the kind of blood flow to the lungs.
You got a question on Zoom.
Yeah. What do we got?
Hi, thank you so much. I was wondering, so the compression of the phrenic nerve, would that also cause some level of bradycardia in impeding the diaphragm contraction?
Good, because you're decreasing.
I'm so sorry. Hypoventilation. I'm sorry.
Yeah, it could cause hypoventilation, but remember you have two phrenic nerves, right? Usually the left gets a little bit more compressed than the right because it extends the lung. You'll get a little bit of hypoventilation. That's very end case into itself because we auto-regulate. You'll have decreased blood pressure because your preload is a little low. Your heart will react and get tachycardic. That's way further down in PD. Right? This is usually pericarditis. The number one complaints are I'm having hiccups and having difficulty breathing. And then you look, pericarditis is usually due to bacterial infection or systemic infection. So they'll have other symptoms that go along. Good question though.
Thank you.
So now that we got that pericardial infection over and we're doing well there, we know where our phrenic nerve is, right? We know where the vagus runs. Now we're going to look at blood flow to the lung. So I always like to divide the heart, and this is a little ahead. This is maybe for next week. I want to kind of give you a good way consonants to get it is we want to look at the heart as two sides. It's just a pump. It's a very important pump. We want to look at deoxygenated versus oxygenated blood. Okay? And when we look at our great vessels, that pulmonary trunk, it comes up and it's going to make a T split. Okay? That's not good for blood pressure. Anytime you come to a 90-degree angle, it decreases your pressure, but you're only going to the lungs and you're bringing deoxygenated blood. So you have to come from your right ventricle. But that's why your pulmonary trunk makes a T to the right and to the left, bringing deoxygenated blood. That means your aorta wraps over it. It wraps over it. I know most of you have done plumbing in your lifetime, right? And if you haven't done plumbing, all of you have driven onto a highway. When you drive onto a highway, isn't there an on-ramp? It's so you maintain speed. Also, when you get off a highway, do you just stop and cause a car accident? No.
Only in New Jersey.
Don't get me started, you can't even take a lap. But what happens is we're trying to maintain speed, and your aorta is oxygenated blood, so valuable, but you gotta pump it all the way to your toes. So you want to increase the amount of blood pressure significantly. You don't want to decrease. That's why there's a gentle arch. Does that now kind of make sense? So when you look, you're going to see the arch of the aorta gently going over that pulmonary trunk, because it's only got to go to your lungs. And your aorta, histologically speaking, isn't made with a lot of tunica media of the muscle. It's made with a lot of fibrous collagen that has to resist pressure. Side note, when you do this, don't you understand? But what happens is that the aorta it doesn't respond to epinephrine or norepinephrine. It doesn't respond to your alpha ones, right? Because there is no muscular tunica media. It's more fibrous than that. Okay? But it's that gentle arch that makes it go from slightly anterior out of the heart to wrapping posterior, going down that posterior mediastinum. It's really important. So when you start having injuries, right, the pulmonary trunk was an artery and still is an artery, and that the aorta is an artery. Imagine there was a shunt in between, because none of you are attached to your parents anymore. No comment. So when we were attached to our parents and we had a little umbilical cord, where did our oxygenated blood come from? It didn't come from the lungs. So both sides of the heart, we wanted to get oxygen. So we had a little gap between a little artery between two arteries that turned into a ligament between two arteries. That's where that shunt came from. That's where your ligamentum between two arteries came from. A ligamentum arteriosum. Can we do the Harry Potter spell? Literally what it sounds like, right? So that the embryological reason was we weren't breathing as babies. We were getting it through our umbilical veins and arteries, oxygenated blood, and getting so it had to come up, and it literally went to the wrong side of the heart, right? Because it went up your IVC essentially, right? And we wanted to share. And that was one of the bridges that helped us share. Does this make sense? Okay. Dr. Morgan's going to go more into it. I wanted to make sure you knew that, because it makes common sense when we think embryologically we're not getting air from our lungs, they're not developed yet.
For those of you that are interested, development of the heart, the cardiovascular system is next Thursday. I have posted on Yuja a video on heart development that I did as part of a supplemental session recording either 2 or 3 years ago. Rather than watch the cardiovascular system development videos that are posted through Canvas, I would watch that video first on development of the heart. And that will help you to understand what Ms. Rosenthal is going to be talking about. And that's where I demonstrate the usefulness of the Harry Potter spells. So,
One question right now. What do we got? I'm finding this a nice part. So now you want to look at it. We want to know that the aorta comes out of the left ventricle and it's going to be going posterior, because what? Having it toward the surface isn't a safe bet. But having it sheltered by your vertebral bodies, that's a little bit safer, right? So we want to think of the rib cage as what? Where your most amount of protection with the ability to move. All of you can breathe, that means all of your ribs have to move, okay? Now your brain doesn't have to move, right? So it's encased in a whole ball of what? Bone. We want to think of that. All right. Any questions? Anybody want to ask anything? We're doing okay. Is this making sense?
So
So now-
typical things that we ask on the exam. The order of structures from anterior to posterior in the superior mediastinum. I mean, you've talked about the superior mediastinum, you know what's there. You have veins, you have arteries, you have the trachea, you have the esophagus, you have the thoracic duct. Yes, you have the thoracic duct, maybe not. You have sympathetic chain, vertebral bodies. What's the order of structures from anterior to posterior? And let's ignore skin. So,
Not gonna ignore skin, just gonna ignore skin. But we're gonna go like bone, right? And so do we want our arteries more anterior to be bitten by a tiger? No. So if we were maybe gonna survive, right? Wouldn't our veins kind of be more anterior, right? So we're gonna kind of look at it in a survival standpoint, learn from anterior to posterior, because then you can answer questions. Patient had a superficial wound on the anterior aspect, right by rib number 1 and 2 in the middle mediastinum on the right. What most likely got injured first? That would be a question I might get. Does this now make sense? Okay. So we want to make sure we know kind of orientation and location, because clinically you're going to go out in the field and your patients, they do dumb things. Like, I don't know why they play with nail guns or like
oh, come on, they're fun.
yeah, they're fun, but not fun while drinking, pointing at your friend, right? Like this, like I've had the weirdest things. You know, I went up on a ladder. Well, okay, did you have anybody hold the ladder? No. Okay, well, you fell on some broken glass. How did that happen? Well, I went up and I had a few beers, and my friends were laughing at it. I dropped the bottle, and then no one was holding the ladder, so then I fell off the ladder onto that bottle that I just dropped. Oh, that's great. That's awesome. What were you wearing? Flip-flops. Oh, okay. Wow. Like, what are you I told you I'm scared of gas stations in America, right, Dr. Mormon? Right? I'm scared. In America, you can fill up your vehicle that can go to like 120 miles an hour with liquid flammable stuff, and no one cards you like how smart you are, right? No one cards you when you buy gas. You can go outside and buy alcohol, right? And buy cigarettes with stuff that's highly flammable and can explode. This doesn't seem like a good idea. And then you can drive away at high speed. Yeah. All right. So now we need to know locations. We need to know injuries, right? What we got, Tom?
I was just gonna say, in that hypothetical, what would most likely be?
First of all, his pride was hurt. Second, he ended up fracturing the ribs. So my job was to palpate the front of his ribs. His left ribs weren't moving well, right? And then he had a cut on the left rib before he fell on the bottom. He was leaking air pretty good.
Oh, I didn't mean the patient fell off the ladder.
Oh.
I meant, for the T or rib 1 to rib 2, like the order of
On the right-hand side?
anterior to posterior.
All right, so he was looking at the one that's doing the rib on the right hand side. So T1 to T2, right hand side, you know your superior mediastinum. You know most anterior to be there is going to be your SVC, right? So that would be the one that's most likely injured first. That would be the way I go through my problem. I say, where am I from the sternum joint? That can tell me where I'm going to be at location wise. I look on right hand side versus left hand side because there is no SVC on the left hand side. And then I can look on the right and say, okay, we got our SVC. Remember dissection lab? You saw the SVC on the right hand side, and then you saw the arch of the aorta. So this is how you're going to systematically work your way through. Next one is we now look at the trachea. We look at the trachea, it comes on down, it's a C-shaped ring cartilaginous, the esophagus is behind it. Below that sternum joint, do we have a trachea? No. So one of the trick questions they always put out there is, oh, posterior mediastinal injuries, and they put the trachea, and for some reason everyone wants to put down your trachea. But we don't have a trachea after that sternum joint. Right? It's split at the sternum joint, at the carina. Yeah. We don't have air in our stomach, or we shouldn't, right? And so there we go. So that's one thing you want to know, what stops at your superior mediastinum. and what continues in your posterior mediastinum, and what continues in your middle mediastinum. So we're going to look at what always at vertebral level, T4, that's sternum joint. That's what we want to look at. How are we doing so far? Does this make sense? Thumbs up, thumbs down. That's why it's very good for you to know your anatomical markers. The next is we want to know developmentally, right? How the lungs came to be, how the heart came to be. When Dr. Mormon goes on to the video, it's very important to know that we started and then we rotated down to make that diaphragm. Once you understand that we rotated down to make that diaphragm, right? Then, yep, that's exactly it. Once we rotate down, you'll see why that phrenic nerve traveled down, why your lungs develop that, and why your heart comes down and starts twisting. Please take time to go over that in depth. Use Play-Doh if you have to. It becomes much easier to do little by little, so you know where you are.
During development, in the adult, my mouth is above my heart and my heart is above my diaphragm. Let's keep that relationship constant, but let's take the entire thing and put it on the back. Now my mouth is, now my diaphragm is the highest structure on the back of the embryo, and then the heart, and then my mouth. So how am I going to get my mouth from the back of the dorsal surface of the embryo to the front? I'm going to do cranial folding. But when I do that cranial folding, the relationship between the mouth, the heart, and the diaphragm, the septum transversum, that's going to stay the same. And so when they come around, my mouth ends up above my heart, and my heart ends up above my diaphragm, which is septum transversum. That's why you have to do cranial folding, because the mouth's on the back of your body. So way back, trilaminar embryo, like foundations, the last interactive session of foundations. How long ago was that? It's in that video. So we will return to that.
Even if it's just for 15 minutes before you do the embryo development of the heart, GI, always go back to that video. I know you don't want to, but for 15 minutes, it's a good way just to refresh. And every time you do it, even if you do it just once or twice a week for 15 minutes, like, all right, let me refresh. This turns to this, this turns to this, this turns to this. When you watch the videos, you won't get frustrated and just, go to sleep like a baby trying to hold his head up. Because it's hard to pay attention because you don't have the background of what goes where. You do that video first and then go forward. It's so much easier to do it that way.
I think I'm going to be a trilaminar embryo for Halloween.
Nice.
Be a flat disc with, and this will be the dorsal surface, so it'll have a mouth.
So, unlike physiology and unlike biochemistry, right? When anatomy, we look at a few things that happen. A, if you got shot stabbed. B, if you had a tumor growing. Or C, if you didn't develop. Okay? So when we look at embryo, I want you to take the theory that what happens if I didn't develop, or a step in my development didn't happen. That's the important thing to look when you look at embryo. Like, oh, what would have happened if this didn't develop? Oh, this should have happened at this time.
Heart murmurs. Heart murmurs are congenital abnormalities of development of the heart. Got to be a way to turn that off.
I love it. It makes you so serious. And so that's kind of sometimes the way I always tell people to look at stuff. Okay. And so you want to look at embryo as what should have been, what could have been, right? When I'm making a cake, I know what it should look like. I know what I want it to look like.
So then he asks his wife to make it.
Actually, this is on record. This is on, I am a better cook than my. I worked in my grandfather's restaurant since 12. Okay. Someone taught her how to make sauce. Okay. It was tough days in our first marriage. The first few years, I lost a lot of weight. Anyways. But we know what it should look like. So your step from embryo, it should look like this. So what didn't develop if the cake is flat? What isn't there if the candles aren't there? You want to think of, you know what it should look like. What did you start with and how did we get there? And where did we go wrong? That's what you want to look, right? And so that makes it a lot easier when we do embryo. When we do gross anatomy, all the things should be there. So now we're looking at what happened if that thing had a tumor on it, got shot, got cut, or didn't show up. That makes it a little easier on looking at questions. That's why orientation is so important, because you know it's there. Now you can know what got affected, and then now you can know the symptoms or outcomes because of it. So let's go to one is, let's look at the esophagus. Where is it? It's in the mouth, the superior mediastinum, then it goes to the posterior mediastinum. Perfect. You now know location, you now know where it is, you now know when it went to the posterior mediastinum, 4 level. So now you can look at injuries and say, hey, I had a tumor at the posterior mediastinum at the T8 level on CT scan. This patient may have these symptoms or signs. You might say difficulty swallowing food all the way down to this. You see what I mean? But they wouldn't have any airway problem because you know it's T8. You know it's no trachea in that airway. You know what I mean? And you know it's in the vertebral body to the posterior mediastinum. So we know there's no cardiac issues, right? So you just work your way through this chain because you know where you are. This is a better way to go through the question than just memorizing factoid after factoid and trying to fit them in the puzzle. Any questions from the chat? Any questions here? So let's look back at the T8 level. Where is T8 vertebral level? Is that below that sternum joint? Yes. Okay, so now you can look at, is there anterior, middle, and posterior? I said you have a tumor on the posterior T8 level, right by the vertebral bodies. Are we thinking lung? We're in that mid-clavicular line. So we're posterior mediastinum. What do we have in the posterior mediastinum? Do we have the heart? No. Do we have the lungs? No. We don't have the trachea because it's gone by what? T4 vertebral body, right? So we have the esophagus, right? We have some of the esophageal system, right? We have some of our lymphatic system, right? How about our phrenic nerves? Our phrenic nerves in the posterior mediastinum, so we don't have any phrenic nerves. So that's how you need to look at this. You need to look at location, what's in it, what can be damaged. Don't just jump. Say, where are we? What is in here? Now what can get damaged? Does this correspond to the signs or the answers that we have? You see what I mean? You should be having a nice conversation of like, where am I? I'm not here, so I don't need these words. If I'm not in the superior mediastinum, do I need great vessel words? Not at all. If I'm in the posterior mediastinum, do I maybe have to look at my descending aorta? That's because it's in the posterior mediastinum. Do I have to look at my carotid? No. Right? So once you start dividing out by these anatomical segments or by their function, it becomes much easier to go through your notes and your questions. When you guys are studying, and you don't have to take my advice, but I tend to do this. What are we doing here? What are we doing here? Why is this so important? I'm in the cardiac, okay, I'm here, I'm the pump. I'm in the lung, I'm here for respiration. I'm in the trachea, I'm here to move the air. Once you start going by function, then you can say, well, if it's got the same function, it's probably gonna have the same nerve innervation. If it's got this function, probably have the same blood in it, you know, blood. Then you start piecing things together versus learning details. Because your brain's gonna get filled up by finals. There's only so much we can go on. Dr. Mormon, any questions you want me to go over anything? There's only one lecture. So
I'm curious whether the vagus nerve is found in the posterior mediastinum. I know it's in the superior mediastinum on both sides. Is the vagus nerve in the posterior mediastinum? Let's think about the most superior aspect of the posterior mediastinum. We know you have a right and a left vagus nerve coming down in the superior mediastinum. On the right-hand side, it's going to cross over the aorta. It's going to give off its right recurrent laryngeal nerve, which will hook under the aorta, and then it's going to head to the esophagus. On the left, it comes down into the posterior mediastinum and heads to the esophagus. So in the superior aspect of the posterior mediastinum, you have vagus nerve. But after that, it's a vagal plexus around the esophagus. So for most of the posterior mediastinum, there's no identifiable vagus nerve. There's a vagal plexus around the esophagus. And then just before the esophagus goes through the diaphragm, that vagal plexus coalesces into an anterior and a posterior vagal trunk. So you went from a right and a left vagus nerve to an anterior and posterior vagal trunk. That means that there has to have been a 90-degree rotation. So which one was the right vagus nerve and which one was the left vagus nerve? The stomach is on the left-hand side. It was originally a midline structure, and that gut tube rotated over so that the stomach moved over to the left. So what was originally right vagus nerve came around and became the anterior vagal trunk. And what was originally left vagal nerve came around and became posterior vagal trunk. But in between, it's vagal plexus. So my understanding was that the diaphragm is considered the floor of the mediastinum, and so it's not included. The diaphragm is not in the mediastinum. So is the diaphragm considered included in the posterior mediastinum? Where did that go? It looks variable since it's only the top of the dome, but is it still included? It is the floor of the mediastinum. It's not in the mediastinum.
these kind of everything in the thoracic cavity itself, the diaphragm is the bottom floor, right? The next one about the vagus plexus, it looks like cobwebbing on the esophagus. So in dissection lab, you're gonna see the vagus nerve, and then when you see the esophagus, you'll see like the cobwebs on it. And that's the vagus plexus. It's the only way I can explain it.
I always called it a gamish of nerves. And when I was teaching in Texas, my first faculty position, and I said, it's a plexus, it's a gamish of nerves. And they looked at me like, it's a what? I said, it's a whole passel of nerves. But if I said to you guys, it's a whole passel of nerves, you'd look at me and go, a what? It's a gamish of nerves. It's basically a network and web. Yeah.
So then we gotta know, what is the vagus nerve? When you go to Vegas, where do you go? You don't go to gym, you guys are broke. You go to the free buffets. You go to restaurants. Okay, I go to Vegas for the buffets. They got some big dim sum, crab legs. I'm there to rest and digest. Okay, so we want to know it's going to travel down your esophagus, right? It's going to be working on giving you peristalsis, and that's the easiest way we can get the parasympathetics to get to the stomach and all your GI tract. Now, it makes sense? That's why it travels down the esophagus. If I go to the interior.
Any other questions?
I'm supposed to use it to rotates. Vagus plexus itself wraps around the esophagus itself. It just looks like cobwebbing. It's indistinguishable from right to left. It just looks like a coating around it.
How many of you have seen the fishnet shopping bag? If you take that fishnet shopping bag with nothing in it and stretch it, it's like a string or a rope. But when you put stuff in it, it spreads out and it has this webbing. That's what the vagal plexus is. It was originally a rope, and then it got to the esophagus and it stretched out and it became a plexus. And then it got to the diaphragm and it coalesced again into two ropes.
You ever seen the sausage or ham at the old Italian deli? It's got in the there you go. But you got to think, right? Why? Our esophagus has tons of muscle. We don't want acid to come up, right? So what kind of plexus do we have in there? We got, muscular plexus. We got muscles in there. It has to be coordinated. And so we want coordinated all at once. If you just had two nerves, it would just contract, but it would contract the whole thing at once. Contracting the esophagus, the whole thing at once, versus making it move in a snake-like pattern, which would be beneficial. That's why when you swallow, you don't just instantaneously explode. Right? Like you want a controlled peristalsis to have a bolus go down versus your esophagus contracting and you explode. That's that.
The field plexus device, we can lower down the esophagus. What is
Where did your esophagus? Good question. You want to know where the esophagus was innervated on the higher part, right? And so your esophagus on the higher part, when you're in your airway, kind of your upper, right? Your esophagus actually changes right around here. It's a very simple innervation by the vagus. It's when we start getting toward that sternum joint, we get that posterior mediastinum. That's where it starts getting into the cobwebbing part. It's easier to innervate all according that way.
So when you think about it, becoming a cobwebbing structure makes it less likely that either expansion and contraction of the lungs or the heart beating is going to injure the vagus nerve and affect your ability to swallow.
Well, every heartbeat is in your aorta on the left, right on top of your esophagus. So if every heartbeat you have indigestion, right? Because that aorta is going to get slightly bigger, the heart's going to pump, right? If you have one nerve, it's easy to compress. If you just have a film, you're only going to compress maybe one or two parts of the film, but the rest of the parts are still free.
Yeah, they describe agita as heartburn. Why is heartburn? It feels like burning and sensation in my heart. It's because you've stimulated the vagus nerve, and the vagus nerve also innervates the heart. It's not actually pain from the heart itself. It's pain associated with the esophagus, the distal end of the esophagus. It's kind of a referred pain.
Dr. Mormon, our time today is done. You're 2 minutes over.
Notice it didn't do the thumbs up. No. Keep my thumbs down.
I'll see you Tuesday, Dr. Mormon. Have a great weekend. I hope you feel better.
I feel better already. Thank you very much. I should be in on Monday. So.
Excellent. Enjoy your weekend, well, everyone.